The various imaging modalities, we will have the various investigation of choice general principles, contrast media, radiation units. So let's start with types of radiation. So the types of radiation can be electromagnetic radiation or particulate radiation. Particulate means the particles, the subatomic particles, and electromagnetic radiation, it travels as photons. The best example of electromagnetic radiation in our day-to-day life is visible light, but we don't use it in imaging. Why? Because the light does not have that much energy, that much penetration that it can penetrate the body and form an image. So for medical imaging, you need some radiation which has good enough energy, good enough penetration so that it goes through this and it forms an image. So the examples of such electromagnetic radiation are X-rays and gamma rays. Okay, they are X-rays and gamma rays. Coming to particulate radiation, so particulate radiation is alpha particles, the beta particles, the neutrons, these are particulate. Alpha particles, nucleus of helium is positively charged, beta particles like electrons negatively charged, X-rays, gamma rays, they have the electromagnetic radiation has no charge. Now going to damage and penetration of these various radiation, remember the damage and penetration, they are like a seesaw effect. If the damage is more, the penetration is less. So understand it like a radiation which has a high penetration, it just goes through the body like a swish and it is not staying in the body to cause a lot of damage. The radiation which has less penetration, it stays in the body and causes damage to the body. So the relation here is inverse relation. So maximum penetration, if I talk about, it is for gamma rays. Gamma rays more than X-rays, more than beta, more than alpha. The damage ka sequence is going to be the opposite. Alpha will have maximum, then beta, then X-ray, and then gamma. So alpha particles are the most damaging. When I say most damaging, that means it has the maximum ionizing power, right? It has maximum ionizing power. Now going to tell me very important and frequently asked question, there's no radiation in which modalities? Very important, remember USD, ultrasound and MRI have no ionizing radiation. That means they are not causing the damage because ultrasonography, ultrasound is basically using sound waves and MRI uses radio waves which are non-ionizing. Remember that X-ray, CT scan, fluoroscopy, right? All of these are having radiation. All the modalities in nuclear medicine which uses gamma rays, all of them have radiation like PET scan, the various scintigraphies, right? But important, USG and MRI do not have radiation. That's why in pregnancy, right, we do USG and CT is contraindicated, which has a lot of radiation. Going to the various modalities now, X-ray or radiography. So in the X-ray machine that you see, the most important component there is the X-ray tube which is producing the X-rays. So what is the mechanism of these X-ray production in X-ray tube? So in the X-ray tube we have this cathode which is like a filament. Now this cathode is the source of the electrons and it has the anode. So when we heat up this filament to very high temperature, then the electrons come out from this filament. So the process is called as thermionic emission, which is being seen at the cathode. Therm, heat, ion, electron being emitted. So with heat, the electrons are emitted out, they go towards the anode, they hit the anode, and this kinetic energy of the moving electrons, it is converted into X-rays. 99% it is converted into heat and 1% it is converted into X-rays. So the production of the X-rays in this routine X-ray tube, the production is by the mechanism called as Bremsstrahlung radiation. What is this Bremsstrahlung radiation? So Bremsstrahlung radiation is the electrons going towards the anode. In this anode we have tungsten, the nucleus which has positively charged, the electrons going towards it. So the electron is getting attracted towards this positively charged nucleus, it is getting deflected, right? And now the electron which was going with, let's say, a particular energy X is now deflected by this nucleus and now the energy becomes, let's say, X minus 10, the energy decreases. So basically the electron beam is getting deflected, its energy is decreasing. So the 10 wala extra energy which is there, right, it is losing some energy. So that energy which is lost, you know that energy can neither be created nor destroyed, it just gets converted into other form. So that is what produces the X-rays. So this X-ray basically produced by the deflection of the electron beam, that is what is Bremsstrahlung radiation, also called as braking radiation. The electron beam is applied the brakes by the nucleus of the anode, right. So that is the most common mechanism here in a routine X-ray tube. So what is the component, the substance that this cathode is made of? It is tungsten, and remember the symbol for tungsten is W, not Tn. Even anode has tungsten, that is W. In the cathode you have tungsten plus thorium, Tt. In the anode you have tungsten and rhenium, right. So that is how the X-rays are produced, and they come out from the X-ray tube. And now the X-rays which are coming out from the X-ray tube, they pass through the patient, and depending on the energy of the X-rays that are coming out, the X-rays have various fate. If the X-ray beam has high energy, it will penetrate and form the image. If the X-rays have low energy, staying in the body, and they will cause damage to the body. And some X-rays get deviated, get deflected, like scatter radiation. So what is the various fate of the X-rays? One, high energy, they form the image. Second, some of them get absorbed and they cause damage to the body, those are the low energy ones. And some are getting scattered, scatter radiation is being formed. Remember, the effect which produces this scatter radiation is the Compton effect, okay, that is the Compton effect. And the effect which is basically producing the contrast in the X-ray image, that is the photoelectric effect, right. Just remember these terms, we have discussed this in detail in the main videos, right. In the rapid revision we are just sticking to the main points, right. Now this is the cassette, which is the X-ray film holder, which holds the X-ray film, right. So this X-ray film that you have, the emulsion which is present, the active component, remember it's a silver halide, maximum being silver bromide, okay. So the silver ions are very important component here, silver halide, silver bromide being the maximum. Look at this, what is this investigation being carried out? This is DR. What is DR? Digital radiography. So what happens is, when you just press the button, and so this X-ray is coming out, they will pass through the patient, and this is the digital detector there, which will detect and reconstruct the image, and you directly get the image on the computer screen instantly. So digital means you are getting a digital image now instantly, unlike conventional radiography where you have to develop the film and it takes time. So the advantage with DR is it is very fast, because it is digital image. You can share it across with anyone, right, sitting across the seas as well. So the communication is possible. And intra-hospital you have something called as PACS. What is the full form of PACS? Picture archiving and communication system, not computerized system. This is archiving, not acquisition. So even this is important. Remember the full form of PACS. So PACS is a system which is picture archiving and communication system, which allows the communication of the images in the various departments in hospital. So for example, let's say that a patient has undergone digital X-ray in the radiology department because of fracture. The orthopedic consultant can see that image in his cabin itself. So that is the digital communication happening because of PACS. So going to very important, the black and white principle in X-rays. Once you understand this, it becomes easy to interpret the pathologies, right. So look at these three situations that you are seeing here. What are we seeing here? In the first one, this jar is filled with air, this is water, and this is more dense, which is bone. Look at the X-ray transmission happening. The air, the least dense, there is maximum transmission of X-rays, more penetration, and the image is going to be more black. As the density increases, air replaced by water, there is less transmission of X-rays and the image becomes less black. That means it becomes like grey. As the density increases further, bones allowing minimum penetration, passage of X-rays, and the image becomes white, right. So we will say that bones have maximum attenuation of X-rays. Attenuating X-rays means stopping the X-rays. So maximum attenuation is seen with bones. So remember that air, fluid and bones. So basically that is how it will go from black to white. As the density is increasing, the image is becoming more white. So the 5 basic densities on X-ray that we have, most black is going to be air. Then you have more dense than bone also is metal, then bone. And this is a very commonly area where mistake is done. Out of fat and water, which will appear more dark. So if I ask you out of fat and water, which is more dense, it is not the fat, it is water. Fat is like oil, right? So remember, like oil floats on water, so it is less density. So fat, oil, less density, so it will be more black. So from black to white, if you see, arrange it, it is air, fat, water, bone and metal, right? So this is the sequence that you have here. The maximum transmission with air, minimum with metal, right? Look at a routine normal chest X-ray to understand this. The lungs which contain air, least dense, the normal lungs appear black. The bones that you see here, the ribs, more dense, they appear white. Look at the heart containing blood, more dense than air, it is appearing white. In CT, the differentiation is very clear, water like appears grey, but in X-ray, it appears like white itself, right? So that is how you identify. And look at this fat, the subcutaneous fat here appearing dark, right? So fat also appears dark like air, but not as dark as air. Going to CT or computed tomography, in simple terms, if I tell you, CT is nothing but a 3-dimensional X-ray. So CT also uses X-rays. So will it have radiation? Yes, right? So that's why it is contraindicated in pregnancy. In any female, if you are doing CT scan, you have to ask LMP before doing CT scan, so that you know that there's no chance of pregnancy there. So CT scan is a 3D X-ray. This is how a CT machine looks like. Why is this a CT machine and not a MRI machine? When you will see MRI machine, it is like a tunnel. You will not see the back wall of the room. This is just one circle here. You can see the back wall. That means this is not a tunnel. So this is a CT machine that you are seeing here. Now this round part, the gantry of the CT machine, is where you have the X-ray tube and the detector on the other end. And the different thing here in CT as compared to X-ray is, this X-ray tube is a rotating X-ray tube. It is a rotating X-ray tube that is used here. So the X-ray tube rotates around the patient. So basically it is taking the images from various angles, and that is what makes it 3-dimensional. How much time does it take for a routine CT brain? It is hardly like 2 minutes. While MRI brain takes like 30 minutes minimum, half an hour is what it takes. So CT is very fast, and that is why generally it is the investigation of choice in emergency conditions, right, where you want fast imaging. Okay. Now look at this. How do you identify this is CT or MR? CT is a X-ray. So whatever you had the black and white principle in X-ray, the same thing will apply to CT as well. So if you see bones in CT, that will appear white, air will appear black. So look at this image in radiology, the imaging. Remember that your right is patient's left and your left is patient's right. The image that you get is a patient lying supine, and you're looking at the patient from the foot end. So the patient is supine, you're looking at the patient from the foot end. So the left side of the patient is actually your right side. That is how it is. The vertebra, the spine will come down. The patient is lying supine. So the lower part of the image is where you will get the spine. So this is the vertebra, and still this is the left side. This is the common query that I get from the students. If this is posterior down, how come this is left side? Because this is a supine patient, you are looking from the foot end. So visualize yourself and you would understand it. Right? So this is anterior, this is posterior, this is left, and this is right. So look at the vertebra here, look at the ribs here, the bone is appearing white, so this is CT. This image also is CT. So what is the difference in between these two images? This is a non-contrast CT and this is a contrast enhanced CT. How do we know that? So contrast enhanced CT is basically where you are giving contrast. How is the contrast given? IV. What contrast is given? In X-ray based modalities, we give iodinated contrast. Iodine, radiodense, it appears white on X-ray and CT. So this contrast, iodinated contrast, goes into the heart. From the heart, it goes to the entire body through the vessels. So the vessels contain iodine in contrast enhanced scan, so they will appear more white, right? So look at the image here. What are we seeing in this image? In non-contrast CT, look at this structure just in front of vertebra. That circular structure is the aorta. Look at the aorta here. The aorta is appearing white here, right? Telling you that this is a contrast enhanced CT. This is not a calcified aorta. This is contrast containing aorta. So if the vessel is appearing gray, it is non-contrast CT. If it is appearing white, it is contrast enhanced CT. Why do we need contrast? So look at this image. This is the liver. This is the liver of the same patient, non-contrast, contrast scan, the scan done at the same time. You are not seeing any lesion in the non-contrast CT, but you are seeing these enhancing lesions in the contrast enhanced CT, right? So what is happening is, if the lesions are of the same density like the liver, they will get camouflage in the liver, that parenchyma, in non-contrast CT. When you give contrast, the lesions taking up more contrast as compared to the liver, so they will appear more dense, more white, and they will stand out. So imagine if this was a patient of CA breast and you just did a non-contrast CT, we will miss picking up the liver metastasis. So that is why if you are suspecting any lesion, any space occupying lesion, you have to do a contrast scan, right? So CECT is very important to pick up any space occupying lesion, like in this case liver lesions, any tumor like brain tumor, any lesion, you have to do contrast scan. Any infective or inflammatory pathology, also you do a contrast scan. The contrast given is iodinated contrast. Most commonly used is iohexol. It is low osmolar, non-ionic, so relatively safe. The contrast is given IV. And what test you need to do before giving contrast? Because this contrast is excreted through the kidney, there is risk of contrast induced nephropathy. We have to look at renal function test, the kidney function test. Easy way of doing that is serum creatinine. So you have to check serum creatinine before giving contrast. So what is the use of non-contrast CT? Non-contrast CT is investigation of choice for pathologies, for conditions where they are already white on non-contrast CT. So you don't need the contrast to make them white. So the pathologies, the lesions which are already white. So what is already white on non-contrast CT? One is calcification, like bones, calcium, calcification is white. So example, renal stones, right? The urinary tract stones, renal stones, ureteric stones, they are calcified. So non-contrast CT is enough. Versus, remember, gallstones, they are not calcified. For gallstones, the investigation of choice is USG. Second thing which is white on non-contrast CT is acute hemorrhage. Acute hemorrhage is white. When I say white, remember it is hyperdense. Why is acute hemorrhage white? Because acute hemorrhage contains RBCs, the fresh RBCs, which increase the density of the acute hemorrhage. So increased density, more dense, hyperdense. Hyperdense means white. So acute hemorrhage pathologies, what are the acute hemorrhage pathologies? Like head trauma, right? You will go for non-contrast CT. So remember, for calcified pathologies, for acute hemorrhage, we go for non-contrast CT. So there is this concept of HU value in CT scan. What is this HU value? HU stands for Hounsfield units, right? So after the name of Godfrey Hounsfield, who invented the CT machine, we have this Hounsfield units. So the HU value of a substance depends on its density, not the mass density, but the electron density, or the attenuation coefficient of that substance. So a substance which has more attenuation coefficient, it is more attenuating, it will have more HU value. Like we saw in X-rays, bones have maximum attenuation, so they have HU value also which is high, right? So a substance, in simple terms, less dense substance, less HU value. More dense substance, more HU value. So imagine HU value, the HU scale is like a number scale, numerical scale, which has 0 in the center, positive on right side, negative on left side. The 0 in the center is what substance? Water. Very, very important, recently asked question. So water, distilled water is what is HU value 0. So that is the reference value. Whatever is more dense than water will have positive HU value. So like bones, metal, positive. Whatever is less dense than water will have negative HU value, like air and fat. Air will be more negative, minus 1000, fat minus 52 minus 100, and bones is 1000. So remember it as beware, okay, beware. Bones, water and air, it is plus 1000, 0 and minus 1000. Okay, fat is minus 50 to minus 100. So air is very dark on CT. So air appears jet black. Fat is dark but not less dark. So it is called as like dirty black appearance. It is black but not like jet black. Right? So remember that increased density means increased HU value and it appears white on CT like on X-ray. Negative HU value is for air and fat, air minus 1000, fat minus 52 minus 100. So let's have a look at this image. First of all, this is CT because the skull bone is white. Look at the CSF appearing dark because it is low density. And look at this pathology here, which is more white, that means more dense as compared to the normal brain parenchyma. Look at this one, it is more white as compared to this pathology, it is as white as the bone. So a pathology which is as white as the bone, it's going to be calcification. A pathology which is white but not as white as the bone, it is acute hemorrhage, right? Look at how acute hemorrhage is picked up on CT as the white area but not as white as bone, very, very important. Out of grey matter and white matter, if you see which has more HU value, the grey matter is more as compared to white matter. Why? Because the grey matter is the cell bodies which is more dense. The white matter is the myelin which is fat which is less dense, right? So the grey matter HU value will be more. Look at the pathologies and let's try to understand these HU values application. So first one, look at this pathology, very, very white. It is giving this streaking artifact which tells you this is very, very dense like a metal. So remember, like metallic foreign body. CT scan is the investigation of choice. Remember, MRI is contraindicated. Any metal, MRI contraindicated there. Okay. Look at this one, white but not as white as the bone. So this is acute hemorrhage. Look at this one. This is black, absolutely jet black. So this is air containing pathology like pneumothorax. Look at this one, the kidney, the left kidney, the right kidney has something which is black but not very black. It is dirty black. That means fat containing lesion. What is a fat containing lesion here? Angiomyolipoma. We have discussed this more in urinary tract imaging, right? So for now, remember this dirty black appearance is the fat which is angiomyolipoma. NCCT versus CECT, this is something we have already seen, vessel white, vessel not white, right? So that is how you differentiate. Coming to MRI, MRI which is magnetic resonance imaging. Magnetic resonance imaging. So it has the MRI machine which you see. It is like a very, very strong magnet. How do you measure the strength of the magnet? In Tesla. So if you would see out of the diagnostic centers, it is written like 1.5 T MRI, 3 T MRI. So the T indicates the Tesla. How much is the strength of the magnet in our MRI machine? So this is like a magnet. So that is why remember that magnet attracting metal. So metal is contraindicated here. So a pacemaker is a contraindication for MRI. So our cochlear implants, aneurysm clips, right, the recent implants that we see like in the knee and all, those are made of titanium which are MRI compatible. Okay, pacemaker is a contraindication, metallic foreign body you are suspecting, it's a contraindication. How do you identify MRI? Is by this tunnel like thing. So MRI is basically dependent on what element in the body? The protons, H plus, very, very important. It takes the use of gyromagnetic property of protons in the body, right? And in MRI, the bone appears black. So look at these three images that you are seeing here. Please do not get confused by this white outline. This is not the skull bone. The white outline that you see here is the fat in the scalp. Fat on T1 and T2 weighted MRI appears white. the fat is going to be white. So where do you look for bone in MRI brain? If this is the brain parenchyma surface, just outside the brain parenchyma, if you see this black line, that is the bone. So outside the brain parenchyma black line, the bone is black. Outside the brain parenchyma black line, the bone is black. This is going to be MRI. To differentiate CT from MRI, remember you have to focus on the bone cortex to differentiate the two. Now how do you identify these MRI sequences T1, T2 flare? So first of all, look for water. If the water is white, WW2, water white, it is T2. What is the water in the brain? The CSF in the ventricles, the CSF in the sulcal space. If that is white, it is T2 weighted MRI. If the water is not white, the next thing you look for is white matter. If the white matter is white, it is T1. So remember, white matter white, grey matter grey. The anatomy is being followed. Anatomy is your first year subject, so it is 1, first year, T1. If the white matter is also black, then it becomes flare. So look at this image here. What is the white matter you look at? The corpus callosum, the subcortical white matter, internal capsule. So this is the corpus callosum connecting the two hemispheres, the subcortical white matter. So the white matter is white here. So this is going to be T1. White matter is black, water is black. So basically all black is going to be flare. Okay, that's a flare image. Is this clear with everyone? So fluid attenuation inversion recovery, that's the full form of flare. So water white T2, white matter white, anatomy followed T1, all black, it is going to be flare. So in flare, if it is pathological edema, that is what appears white. So that is why to pick up that brain edema, brain pathologies, flare is a good investigation. The rest of the sequences, MRI sequences like DWI, SWI, we have discussed in neuroimaging. Going to UST, ultrasonography, ultrasound. So as the term says, it uses sound waves. So there is no radiation in ultrasound. Now it is using sound waves. So do we hear that sound when we do USG? No. Why? Because the sound is outside the human audible range. It is ultrasound. So the frequency is very high, which is outside the human audible range. Now, in ultrasound, the principle that you have is piezoelectric effect or piezoelectricity. So in ultrasound, the probe that you see on its surface, it has a crystal. What is that crystal made up of? PZT. Remember, like piezo, PZT. What is the full form of PZT? PB, lead, zirconium titanate. This is the substance used here which has piezoelectric effect. What is the piezoelectric effect? So when we do ultrasound, the electric signal coming, it is vibrating these crystals, and that is what produces the sound. It converts this electricity to sound. It goes into the patient's body. From the patient body, the sound is coming back, echoed back. It goes to the crystal again, and this piezoelectric crystal has the property of converting it again into the signal and forming the image. So that is piezoelectric effect. Okay, that is piezoelectric effect. So lead zirconium titanate is used in ultrasound. Remember, there is no radiation in ultrasound. Why do you have various probes in ultrasound machine? Because the different probes, they emit the sound of different frequency. The frequency is different. So what is the advantage of different frequency? That means they will have different penetration. So when you see this probe here, which has this convex surface, convex probes, they are low frequency and they have high penetration. So they are used for deeper ultrasound like USG, abdomen, obstetric ultrasound. Flat ones, the linear probes, they have high frequency, low penetration. So they are used for superficial organs like USG breast, USG thyroid, USG scrotum. And this probe, which is a long probe, is put into the cavity. So this is like for transvaginal sonography, for transrectal ultrasound, transrectal ultrasound, transvaginal sonography, this long probe is used. So two important principles in ultrasound: posterior acoustic shadowing and posterior acoustic enhancement. Posterior means behind, acoustic means sound related, and shadow is black. enhancement is white. Shadow, perchai is black, enhancement is white. So behind something you are seeing black, that is posterior acoustic shadowing. So for example, stones, we all know gallstones, posterior acoustic shadowing. Why do we get that is, so when you are doing ultrasound for gallstones, the stones, the sound reaching there, the entire sound is reflected back, right, from the stones. They do not allow the sound to be transmitted. So what is happening in this area is no sound is reaching in this area. If there is no sound reaching behind the stone, so there will be no echo produced. So if there is no echo produced, there is no signal produced, so that area will appear black. Remember, something which is creating more echoes, it appears more echoes means hyper echoic. Hyper means white. Where there is no echo, there is no signal, it will appear black, right? So remember that stones, similarly bones, not allowing the sound transmission, air, a bad conductor of sound, all of this will give posterior acoustic shadowing, right? Something which is not transmitting sound. So remember, like we said, for gallstones, the investigation of choice is USG. You identify by posterior acoustic shadowing. For renal stones, it is non-contrast CT because they are calcified stones. Calcification is best picked up on CT. Posterior acoustic enhancement. So look at this white area behind this. The more white area, enhancement is white. So something which is transmitting a lot of sound. So because of that, more sound is reaching back, more sound is reflected, it is appearing white. That is posterior acoustic enhancement. So what is that something which is transmitting a lot of sound? It is fluid. Remember, fluid is a very good conductor of sound, transmits a lot of sound. So if there is a fluid containing pathology, what is a fluid containing pathology called as? Cyst. A fluid containing pathology, a cyst will transmit a lot of sound. So behind that, a lot of sound will reach, a lot of sound will be reflected back, and the behind area will appear white. So remember, cystic lesion is identified by posterior acoustic enhancement. How is the fluid appearing? Fluid by itself is appearing dark. Why? Because the fluid is transmitting sound. It is not reflecting any sound. So no reflection, no image, it is appearing dark. So remember, fluid by itself appears black on ultrasound, right? But behind that you will see this posterior acoustic enhancement. So fluid is black on ultrasound. Remember, in X-ray and CT, it is air which is black. Okay. Look at this one. What is this ultrasound image here? This is called as M mode of ultrasound. M for motion, M for movement. This is used for moving structures like the heart. So in M mode, you will see this like line sort of thing which is coming across that structure, and you will see the wave like thing which is produced to show you the movement, how the movement is. So M mode of ultrasound is basically for moving structures like diaphragm. Diaphragmatic palsy में देखना है तो M mode of ultrasound is what you can do. Fetal cardiac activity देखना है, M mode of ultrasound. This one that you see, this is Doppler, again a modification of ultrasound. So Doppler is nothing but ultrasound. So will Doppler have radiation? No, because it is ultrasound, right? So Doppler is the first investigation, screening investigation for vascular pathologies. Okay, so for example, when you have a patient with intermittent claudication, you are suspecting peripheral vascular disease, first thing you would do is Doppler. So in Doppler, basically the sound wave is going to that flowing blood. The flowing blood causes this shift in the frequency of the sound. This is something called as Doppler shift. Doppler shift is nothing but the shift in the frequency of the sound, right? And depending on the direction of the blood flow, you will get the color in the Doppler. So first of all, to get this color image in Doppler, it should be a flowing blood. It should not be static blood. And depending on what direction the blood is flowing, you get the red and blue color. So remember, the red and blue color, they indicate the direction of the flow. Okay, they indicate the direction of flow. They are not indicating it is artery or it is vein. And depending on the waveform that you get, you know that this is artery or this is vein, right? So like if you get a waveform like this, which has a sharp peak, it is an arterial waveform. So that is Doppler, dependent on Doppler shift, the change in the frequency of the sound. So coming to other investigations for vascular pathologies, first we said is Doppler. What is this? CT. And what are you seeing here? The vessels containing the contrast. You are not seeing the brain parenchyma very well. This is CT angio. This one you are seeing the white vessels, but there is no white bone. So this is MR angio, MR angiography. This one you are seeing the vessel but not white but black. The only angiography where you can get the black vessel is DSA, digital subtraction angiography, which comes under interventional radiology, right? So now let's try to understand that. So you have Doppler, you have CT angio, MR angio and DSA. Will Doppler have radiation? No. CT angio? Yes. MRI? No. DSA is nothing but fluoroscopy. This is a contrast X-ray sort of thing. So will it have radiation? Yes. Contrast in Doppler is needed? No. In CT, yes. To make it white, the vessel white, you need contrast. So what contrast in CT angio? Iodinated. MRI contrast can be done without, MRI angio can be done without contrast, because MRI has this power of making these blood vessels look white even without contrast. So what is that sequence called as? TOF. What does TOF stand for? Time of flight angiography, which is used for MR angiography. And in DSA, it is contrast X-ray. So will you need contrast? Yes. What contrast? Because it is X-ray, iodinated contrast. So what do we do here is, in CT angio, you are giving the contrast IV. In DSA, you are going intra-arterial. So this is invasive. It comes under interventional radiology. So you go into the artery, femoral artery, you cannulate it, and then you go to the vessel and you put the contrast. So this is more invasive. DSA is invasive. But the advantage with DSA is, since you are going into the artery, so if there is a thrombus in the artery that you see, you can remove it at that time. So it is therapeutic as well. The rest of them, you cannot treat the thrombus. You are just diagnosing on them. So DSA is something which is therapeutic. So DSA is invasive. So it is not the first thing that you do. You keep it for last, like the gold standard. Doppler is something which is easily available, cost effective. So generally this is the screening investigation that you have. After that comes CT angio and MR angio. So suppose if you have a patient with renal failure, what angiography can you do? MR angio, because you can do without contrast. So in renal failure patient also you can do MR angio. So let's have a quick look at the terminologies. What is black in X-ray, black in CT, USG called as, what is white called as. So remember that something which is black on X-ray is called as lucent, which is radiolucent. Black means radiolucent, like air is radiolucent. White is radio opaque, like bones are radio opaque. On CT, USG, MRI, black is hypo and white is hyper. So in CT, density dependent. So remember it is called as hypodense and hyperdense. Acute hemorrhage is hyperdense. In USG, it is called as black is hypo, USG dependent on sound echo. So hypoechoic and hyperechoic. That is what it is called as. In MRI, black is hypo intense and hyper intense. Hypo intense, hyper intense. Something which is hyper intense on T1. Remember T1 white, T1 bright. Remember fat. It is bright on T2 also. T1, T2 white is fat. How is fluid on MRI? It is T2 white. Okay. But it is T2 dark. So fluid CSF is T2 white and T2 dark. The bone cortex, the fibrous tissue, ligaments, they are both T1 and T2 dark. Going to fluoroscopy. What is fluoroscopy? Fluoroscopy is nothing but, in simple terms, a video X-ray. So when I say video, X-ray is like taking a photo, static image. Fluoroscopy is taking a video. For what do you take video? Moving structures, right? If I'm sitting still here, you would take a photo. If I start dancing, you would take a video, right? So video is for something which is moving. So what is moving in our body? Blood is moving. The GIT peristalsis, that is moving. So angiography, DSA comes under fluoroscopy. The GIT fluoroscopy studies, all the barium studies, they come under fluoroscopy. right? So look at this image here. What is this patient doing? Drinking something. What is that something? Barium. So the barium goes into the esophagus, and you actually get to see in the video x-ray, the fluoroscopy, the image comes on the TV screen like this, and you get to actually see how the barium is moving. Here, this one here is a C arm, C shaped. Where do you see it commonly? In the orthopedics OT, right? So when the orthopedic surgeon is operating, manipulating the bones, the fractures, he wants to see the alignment is good in real time. So that is why we use this C arm, right? So remember that this is something called as this image intensifier, which is used in fluoroscopy, which helps us get an image on the TV screen. So image intensifier is used in fluoroscopy. Again, like a C arm, and you are getting this blood vessel image on the screen. This is digital subtraction angiography. So all these are video x-rays. So fluoroscopy will have more radiation exposure or less as compared to x-ray? Definitely it will have more radiation exposure. Why? Because video is made up of multiple pictures. So if you compare barium studies versus x-ray, barium studies will have more radiation exposure. So that is why in fluoroscopy, which has high radiation exposure, it is important to wear this lead apron, right? Coming to this image here, mammography. How do you know this is mammography machine? By this compression plate which is present. So mammography is nothing but x-ray of the breast with compression, right? Without compression you cannot do mammography. That compression is important. When the breast is compressed, it becomes like more homogeneous, thick, and the x-ray penetration is better. So compression is a must. So any pathology where we cannot do compression, like breast abscess, like acute painful condition like acute mastitis, like a patient with breast implant, there we will not do mammography, right? And mammography is for breast cancer screening basically in a female who is more than 40 years of age. Why not in a younger female? Because in a young female the breast is dense, glandular breast, which is dense breast. So the dense breast will appear white. The microcalcification which is seen in cancer also appears white. So white in white is difficult to pick up. In an older female, the breast becomes fatty, less density, so appears dark, and in that dark breast, the microcalcification will be easy to pick up. So the yield, the positive results that we see with mammography is not seen in a young female. So we do not do mammography in a young female, we do ultrasound. If it's a high risk patient who has positive history, family history of breast cancer, then we go for MRI. So in a female who's average risk female, for breast cancer screening, you go for mammography. But if it's a high risk female, you want to see DCIS, ductal carcinoma in situ, then you go for MRI. A young female with breast lump, you will go for USD. For breast abscess, investigation of choice is USD, right? In a patient with implant, it is MRI. So in mammography, we take two perpendicular views for the breast. The two routine views are craniocaudal, and then you have mediolateral. You make it mediolateral oblique, so as the axilla is also covered, you can see the axillary lymph nodes as well. So the axilla is covered. This is MLO view. You have the two breasts together here, and this is the craniocaudal view of the breast. So that is mammography. A breast lesion, the findings in mammography, breast ultrasound, breast MRI, they are given by the lexicon, by RADS, breast imaging reporting and data system. We have discussed this in the OBGY imaging, in the breast imaging. Going to this one, OPG, ortho RADS, breast imaging reporting and data system. We have discussed this in the OBGY imaging, in the breast imaging. Going to this one, OPG, orthopentomogram, right? So there is this occluded system. We have discussed this in the OBGY imaging, in the breast imaging. Going to this one, OPG, orthopentomogram, right? So reporting and data graphy. A axilla is covered. This is MLO view. You have the two breasts together here, and this is the craniocaudal view of the breast. So that is mammography. A breast lesion, the findings in mammography, breast ultrasound, breast MRI, they are given by the lexicon, by RADS, breast imaging reporting and data system. We have discussed this in the OBGY imaging, in the breast imaging. Going to this one, OPG, orthopentomogram, right? So there is this occluder which is put in the mouth, and then the X-ray tube rotates to get imaging. Going to this one, lexicon, BIRADS, Breast Imaging Reporting and Data System. We have discussed this in the OBGY imaging, in the breast imaging. Going to this one, OPG, orthopentomogram, right? So there is this occluder which is put in the mouth, and then the X-ray tube rotates to get a panoramic view of the jaw, the dentition. So what do you see in OPG? This image has been asked, what is this? This is not a routine X-ray maxillar mandible. This is OPG, where you get all the teeth images together. So basically this is ordered by a dentist. So remember, this is a panoramic view of the dentition of the jaw. It helps in the evaluation of temporomandibular joint as well, but better investigation of course for that is MRI. This is OPG. Identifying the investigations, first one, look at this image, image A, image B. In the image A, bone is white, this is CT. In the image B, this is not the bone, just surrounding the brain parenchyma, this is black bone, this is MRI. Look at this one, image A, image B. The bone cortex is white, the bone marrow is black, but the bone cortex is white, so it is CT. The bone cortex is black, this is MRI. So learning point, look at the bone cortex, not just the bone marrow, to identify it is CT or MRI. Here the bone marrow is appearing dark because it is fatty marrow, so fat on CT appears dark. Here the bone marrow is appearing bright because the fat on MRI, it is bright, right, if it is not a fat suppressed sequence. What is this? Very frequently asked, white bone CT, but you have the orange color, not just black and white. So whenever you have this orange colored CT image, it is PET CT. We have discussed the principle and all of that in nuclear medicine. So PET and CT combined together, this is an example of hybrid or fusion imaging. Right, so remember, PET basically comes under nuclear medicine, CT comes under radio diagnosis, nuclear medicine is functional imaging. Okay, the difference between nuclear medicine and radio diagnosis is, in nuclear medicine the radioisotope going into the body, and from the body the radiation comes out. In radio diagnosis, like in CT X-ray, the X-rays are coming from the machine and penetrating the patient's body, they are not coming from the patient's body. Right, going to this one here, this is a routine black and white, the B mode of ultrasound, and when you see this orange colored ultrasound image, it is contrast enhanced ultrasound, contrast ultrasound image. So this orange CT is PET CT, orange ultrasound is contrast ultrasound. Going to this one, when you see the red and blue color ultrasound image, remember it's not always Doppler. When you see that this is a blood vessel, the velocity is mentioned telling you the blood flow, this is going to be Doppler. But this image here, which is this USG thyroid that you are seeing here in front of trachea, and what is mentioned here in the units is kPa, kilopascals, not the centimeter per second, not the flow. So when you see kPa, it is a measure of strain. So this modality is called as elastography, USG elastography. As it tells you about the elasticity, the loss of elasticity, that is fibrosis in a lesion, fibrosis in the tissue organ, whether the pathology is soft or hard, that can be seen on elastography. So we press that lesion, that pathological area with the ultrasound probe, right, and you get to know whether it is soft or hard based on the color coding. So remember, when you see color coded ultrasound image with kilopascals unit, it is elastography. So for example, in liver, fatty liver progressing to cirrhosis, how much fibrosis is there? You get to see on elastography, FibroScan. This is used commonly in thyroid nodules, breast lump. Okay, so that is elastography. Going to FAST and eFAST scan. What is FAST? FAST stands for focused assessment with sonography in trauma. So basically it is sonography. So FAST is done in a patient of trauma, thoracic abdominal trauma, to look for the presence of the free fluid, which basically indicates blood in a patient of trauma. So in FAST, how is FAST and eFAST different? eFAST is extended FAST. It is extended to include the thoracic cavity also. In a basic FAST scan, we have 4 areas, which is xiphisternum ke yahan, to look for the pericardial blood collection, fluid collection, the right hypochondriac, the left hypochondriac, and the pelvic area. So the dependent areas of the abdomen to look for the free fluid. In the eFAST, you have this thoracic cavity also included to look for pneumothorax and hemothorax. Pneumothorax gives the barcode sign. We have discussed this in respiratory radiology, right? So you are looking for cardiac tamponade, pericardium is also involved. So look at this image, whether this is fast positive or fast negative. You see this black area. Remember, black on ultrasound is fluid. So if you see the presence of the free fluid, it is fast positive. Okay, it is fast positive, telling you that from some organ the bleeding is occurring. So what do you do if the fast is positive? Depends on whether the patient is stable or the patient is unstable. If the patient is stable, you have good enough time to evaluate it in detail, then you go for CECT. If the patient is unstable, no time, you directly go for surgery, exploratory laparotomy. Remember, we also do whole body CT in a patient of trauma, and it includes the important areas like the brain, the cervical spine, the abdomen. Previously asked question, it does not include the imaging of limbs. Limbs are not included in whole body CT. Going to investigation of choice general principles. For air containing pathologies, most sensitive is CT scan. How does the air appear? Black. For fluid is ultrasound. Remember, U for U ultrasound. Fluid appears black. Calcification, C for CT, it appears white. For soft tissues, it is MRI. What does the soft tissues include? The nerves, the muscles, the ligaments, the tendons, right? All these, the intervertebral disc, which is a cartilage. So even the cartilage, it comes under MRI. So when you have a patient with ACL tear, a patient with meniscal tear, right, you will go for MRI. Bone cortex, bone marrow, C for C, cortex CT. For bone marrow, it is MRI. What sequence of MRI for bone marrow edema? Remember, there is something called as stir sequence. Medical device position, for example, pacemaker leads, are they correctly positioned? Central line, endotracheal tube, for that we do X-ray, which is easily available and quick. Vascular pathologies, first investigation, screening investigation is Doppler, then you go for CT or MR angio, and then is the invasive one, which is DSA. For metallic foreign body, MRI is contraindicated, X-ray is the first thing, but more better than X-ray for better localization is CT. For gallstones, ultrasound. For renal stone, CT, because they are calcified stones. Region-wise investigation of choice. For brain, if you want to have a look at the brain, MRI gives you more detailed and better images, differentiating grey matter from white matter, right? But if it is a patient of head injury, then non-contrast CT. To look for acute hemorrhages, there is EDH, SDH, to look for fractures. In which head injury do you do MRI instead of NCCT? It is diffuse axonal injury. What sequence? SWI. We have discussed in neuroimaging. For chest, lung pathologies, air containing, CT is the best, and if it is a mass, mediastinal mass. For anterior mediastinal mass, CECT. For posterior mediastinal mass, when neurogenic tumors are the most common, so neurogenic nerves, soft tissues, we will go for MRI. For upper abdomen, depends on the organ, like for example, if it is gallbladder, fluid containing, so USG. If it is pancreas, then you go for CT. For liver, you have triple phase CT, right? For pelvis, you have ultrasound like transvaginal sonography and MRI, which are most important. For perineum, example like perianal fistula as well, you have MRI, which is now the better investigation. Coming to contrast media. So what are the various contrasts that we use? In all X-ray based modalities, we use the radio-dense iodine, so iodinated contrast medium. Commonly used is iohexol because it is low osmolar, non-ionic, so not heavy on the kidney. The detailed classification of contrast media has been covered in the main videos. So all X-ray based modalities like CECT, HST, which is a contrast X-ray, IVP, which is a contrast X-ray of KUB, ERCP, again which is a contrast X-ray, we use iodinated contrast. This iodinated contrast is excreted by the kidney, can have contrast induced nephropathy, so we need to check serum creatinine before giving this contrast. The most common side effect that you see with this iodinated contrast is anaphylactoid reaction, which is non-IgE mediated. That is the most common. Omniscan, as you can see here, gadodiamide, gado, that means gadolinium, is the MRI contrast. Why do we use gadolinium, not iodinated in MRI? Because gadolinium is a paramagnetic substance. For MRI, magnet wala imaging, you need a substance which has magnetic properties which will change the appearance of the substances, pathologies in MRI. So gadolinium is what is used as a contrast in MRI. Orange colored ultrasound image, contrast enhanced ultrasound. So what is the contrast used here? It is micro bubbles of sulfur hexafluoride gas. So this is a gas, it gets excreted via the lungs. So can you give it in renal failure? Recent exam question. Yes, it is safe in renal failure. The CT MRI contrast you do not give in renal failure. This is excreted by lungs. You can give in renal failure. This is micro bar. The bar here stands for barium. What compound of barium is there which acts as a contrast? It is barium sulfate. Remember, it's not sulfide. It is barium sulfate. It is used for GIT imaging. And it is contraindicated in perforation. Why? Because barium is water insoluble. If it goes out from the perforation site, it will cause peritonitis. So what do we use there? Iodinated water soluble contrast media like iohexol. If you have iohexol and gastrographin both in the options which are iodinated, iohexol is better than gastrographin because iohexol is low osmolar. Going to radiation units. So what is the unit for exposure dose, absorbed dose, equivalent dose and effective dose? So you have conventional unit and SI unit. First of all, remember that conventional units, all of them are starting with R. That is how you remember. First is the radiation exposure. Then comes the absorption. Then comes the effect on the body, and the effect also depends on the type of radiation. So exposure dose first is like the ionization happening. Ionization means creating ion, the charges. So what is the unit for charge? Coulomb. So for exposure also ionization wala coulomb per kg is the SI. Roentgen is the unit for conventional unit for exposure. Remember Roentgen for X-ray discovery, radiation discovery. So first is Roentgen. For absorbed dose, radiation absorbed dose, RAD, it is RAD, the conventional unit. Rad is one color, grey is another color. So remember rad and grey go together. 1 grey is equal to 100 rads. Equivalent dose is for equalizing the various types of radiation, like alpha is more ionizing, right? So remember for equivalent starting with E, conventional unit starts with R, E for equivalent, so REM is what you have here. Sievert is SIE, remember it is the SI unit of equivalent, SI unit of effective. So equivalent and effective dose have the same units, the REM and the sievert. REM starting with R conventional, sievert is SI for SI and equivalent effective. 1 sievert again is equal to 100 REM. So what is the radiation dose that we get in various investigations? So in chest X-ray single PA view, it is 0.02 millisieverts. Okay, it is 0.02 millisieverts. If you look at IVP, it is more, right? IVP contrast X-ray, barium meal, it is more. CD head, chest, abdomen. Imagine like you go down, the dose is also increasing. 2 millisievert, 8 millisievert, 2 plus 8, 10. So it is 2, 8, 10, right, for the CT. All the radionuclide studies, the technetium studies, PET scan, they also have radiation exposure which is there, right. Coming to radiation effects, so the hazards, the effects of radiation can be divided into deterministic effects and stochastic effects in the body. So what is deterministic and what is stochastic? Deterministic, remember it as the threshold can be determined. They will occur only after a particular threshold of radiation is passed. So it has a threshold, typically severe grays, it is specific to particular tissues and the severity is dose dependent. So look at the severity and look at how with increasing dose the severity increases. So deterministic is something where the threshold can be determined. They will occur after a particular threshold and as the dose increases, the severity increases. All the body effects like radiation induced skin erythema, cataract, alopecia, bone marrow suppression, they are deterministic effects, they are due to cell killing. And what is stochastic? Remember it as CHA. Stochastic effect is by chance. It is by chance. That means it can occur at any dose. There is no threshold for that. But definitely as the threshold increases, the probability of it occurring increases. So for example, radiation induced cancer, it can occur at any dose, but as the dose increases, the chance increases, the probability increases. So with stochastic, the probability increases with dose. With deterministic, the severity increases with dose. So this is due to DNA changes, right? Example, radiation induced cancer, radiation induced mutations. All these are stochastic effects. It can start with the minimum, there is no threshold there. As the dose increases, the probability increases in stochastic effect. Going to acute radiation syndrome, where there is sudden exposure to a high dose of radiation, right, more than around 1 to 2 grays, then this acute radiation syndrome occurs. So what happens is, first is the prodromal phase, where there is NVD, the nausea, vomiting, diarrhea which is there. Then comes the incubation phase, the asymptomatic phase. So then comes the asymptomatic phase, and then comes the real manifestations. First to be affected is bone marrow. We have seen in radiotherapy, like bone marrow tissue is very radiosensitive because of continuous dividing. So first comes hematopoietic syndrome, last will come the CNS wala syndrome. So first is hematopoietic after more than 3 grays, and then there is convalescent phase, or there is death. Coming to radiation safety and protection, because radiation does have hazards, right? So there is something called as ALARA principle. What does ALARA stand for? As low as reasonably achievable. As low as reasonably achievable. So whenever you are doing any investigation in a patient, ALARA principle has to be applied. The radiation should be as low as reasonably achievable. That means it should not affect the quality of the image. So reasonably achievable, right? That's the principle there. 10-day rule is something that in a female of reproductive age group, investigation which has radiation should be done in the first 10 days of menstrual cycle, because then there is no chance of pregnancy. TDS principle is time, distance and shielding. The time for which the radiation exposure is there should be minimum. The distance should be more, because if this is a radiation source, as you increase the distance, the radiation reaching that point will decrease. By how much percentage? There is something called as inverse square law, previously asked. Inverse square law is, you increase the distance, the radiation intensity decreases by how much? Square. You 2x the distance, the radiation becomes 1/4. You 3x the distance, the radiation becomes 1/9. You half the distance, the radiation becomes 4 times. So that is inverse square law. And shielding is using appropriate, like lead apron, gloves, thyroid shield, that should be used. So what is the thickness of lead apron? Let's have a look at that. So AERB guidelines in India for protection tell us that the protective aprons and gloves should have minimum lead equivalent of 0.25 mm. The minimum is 0.25 mm, but the most common that we use is 0.5 mm, because according to international guidelines, 0.5 mm is the minimum. Indian guidelines is 0.25. Right? But imagine like we are importing majority of the things that we use, so we get 0.5. So most common used is 0.5, minimum recommended is 0.25. The gonadal shield should have minimum of 0.5. The barrier that is there between the operator and the X-ray tube, that should be 1.5 mm. And in pregnant radiation workers, how much radiation exposure to the embryo? It is 1 millisievert. If it is asked to the mother, it is 2 millisieverts. Imagine 1 to the embryo, 1 to the mother, together it becomes 2. Only for embryo it is 1 millisievert. For whole body, for public exposure it is 1 millisievert per year, that is the limit. For occupational workers which have more exposure, it is 30 millisievert in any single year. Right? So 1 millisievert and 30 millisieverts is what we have here. Coming to TLD batch, TLD stands for thermoluminescent dosimeter. Thermoluminescent dosimeter. So as the term says dosimeter, it measures the dose of what? The radiation that the occupational worker is getting. So for example, when I joined radiology department as a PG resident, we get this TLD badge which has the name written, there's a unique number which is there, and the duration, because this TLD badge needs to be monitored regularly, right, to see that there is no limit which is crossed. So how frequently? October, November, December. It is 3 months. So this is monitored every 3 months. So this TLD batch, behind side if you open it, there are those discs which are there. The active component which is there, it is calcium sulfate dysprosium. In India, in other countries, it is lithium fluoride. So what does this substance do is, when I'm getting the radiation, it absorbs this radiation and keeps it as a latent dose. And when this is sent for monitoring, for measuring that how much radiation has been received. So when this is heated, this disc is exposed to heat, it emits the light, so thermoluminescent, and based on how much light is coming out, we get to measure the radiation. So that is TLD batch. TLD batch, when we are wearing with the lead apron, it should be above the lead apron or below the lead apron? Below the lead apron for true measurement of radiation, because if it is above, so for example, if it is above, it is calculating like 100, but actual that I am receiving because of the apron is 60. The apron is protecting me. So it should be the true value, so you wear it beneath the lead apron. Coming to the PYQs, LINAC, linear accelerator, discussed in radiotherapy, production of X-rays. Best investigation for ureteric calculi, which are calcified stones. Calcified is CT, NCCT. True regarding CT, CT score of water is 0. Unfiltered X-ray beams, no, they are filtered. The X-ray beams are filtered to remove the low energy X-rays which cause damage to the body. It is the investigation of choice for gallstones, no, it is USG. NCCT head 20 millisieverts, no, it is 2 millisieverts, 2, 8, 10. So the correct answer is CT score of water is 0. Bone plus 1000, air minus 1000. MRI machine magnetic field measured in Tesla, remember 1.5 T, so it is Tesla. MRI image given here is the SWI image discussed in neuroimaging, which is very different from T1, T2 flare. You see these veins which have deoxygenated blood present. That is a SWI image. Imaging modality shown here, this is a ultrasound. Okay, this is ultrasound image. Procedure shown is, during the procedure shown, what substance is taken up by the cancer cells. So this is a PET CT which is shown here. The PET is your FDG PET, deoxyglucose. So it is glucose uptake which is seen here. Whole body CT scan protocol for trauma includes all except limbs are not included. Head is there, spine is there, CT abdomen is there. Limbs are not included as we have discussed. Contrast agent safe to use in renal failure, ultrasound contrast. Why? Because it is excreted via the lungs. So that is safe. Recent INICT exam question. Ideal thickness of lead apron to be worn in radiology department. You do not have 0.25 in the option, so you go for 0.5 mm, right? 0.5 mm, right? So that was about the basics, the fundamentals of black and white of radiology. Learn it very well so that it's the systemic imaging ahead becomes very easy for you and you are able to decode even the new images in your exam. Thank you.